of Anything services exclusively for doctors. It is with great pride that Clarnit serves as a digital partner for this event, and the focus of today's session is USGRA upper limb blocks. Now, I would like to invite Dr. Meenakshi Sundaram sir, our distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former National Vice President of Indian Society of Anesthesiologists and has held key positions including Governing Council member, President and State Secretary of ISA Tamil Nadu State Branch. Now, sir, we can proceed with the session. Over to you, sir.
Thank you, Clinton. At the outset, I request our branch president, Dr. Munian, to offer his address.
Good evening, all. I am Dr. K. Munian, President ISA Puthukkottai City Branch. On behalf of ISA Puthukkottai City Branch, I welcome all the moderator, speakers, and the delegates and our academic chairman for the online webinar, which is a 21st episode of second edition of ISA Puthukkottai conducted in the name of Puthukkottai Bhudhan. Today, we are going to discuss about the ultrasound guided nerve block for upper limbs. Nowadays, the ultrasound guided nerve blocks are widely practiced by the consultants and the PGs. What are the benefits of the regional ultrasound guided nerve block? Today, we are going to discuss about the upper limb nerve blocks, which can be divided into clavicle, above the clavicle, infraclavicular, and axillary blocks. Above the clavicle, which is nothing but interscalene block, which is widely used for upper limb and shoulder joint and upper shoulder joint, and the supraclavicular block, which is widely used for the below the shoulder joint, and the axillary block, which is mainly used for forearm surgery and hand surgery, which is mainly used in plastic surgery. What are the benefits of the ultrasound guided nerve block? We can prevent the injury to nerves and also the vascular structures. By doing ultrasound guided nerve block, we can improve our accuracy and the benefits to the patients. Our speakers are from neighboring state, Kerala. Our speakers are interested to share their experience with all of us. Once again, I welcome you all, sir. One more thing, I happily inform you that our ISA City branch is going to conduct an ultrasound guided nerve block and CME for the coming date of coming 14-15 of this month. And one more thing, our academic chairman and my respected professor, Dr. A.L. Meenakshi Sundaram, belongs to our ISA Society, is contesting ISA National President-elect. Kindly requested all support for him to elect as a National President in the coming year. Thank you all. Once again, thank you all. Thank you, sir.
Thank you, Mr. President. I request our Secretary, Dr. Kannan, to offer his Secretary report.
Good evening, all. I am Dr. Kannan, Secretary, ISA Puthukkottai City Branch. Successfully, we are conducting 21st webinar of second edition of Puthukkottai Bhudhan today. Today, our topic is ultrasound guided regional blocks, especially upper limb blocks. I welcome all our eminent speakers to our webinar. Last week, 20th webinar, we have conducted smoothly on 4th June. Last week, our topic was liver transplant incidental surgeries. Our moderator was Dr. Ujjwalraj Dudedia, and we have divided the topic into 3 subtopics. First one is thromboelastogram rotum. Second one is cirrhotic patients posted for non-liver transplant surgery. Third one is liver recipient posted for non-liver surgery.
Webinar, sir, within 10
First subtopic, thromboelastogram, was done by Dr. Grishma Somanath. Second subtopic, cirrhotic patients posted for non-liver transplantation surgery, done by Dr. Aditya Anil Prabhudesai. Third subtopic, liver transplant posted for non-liver surgery, was done by Dr. Prajwala K. Kausik. Last week, around 750 delegates have attended our webinar. Our president has told two main things. First one is we are going to conduct workshop on June 14th, ultrasound guided nerve blocks, and June 15th we are going to conduct CME. I welcome all the faculties and postgraduates to our workshop and webinar, workshop on CME. And second important thing is our academic chairman, Dr. Meenakshi Sundaram sir, is going to conduct as National ISA President-elect 2025. Dr. A.L. Meenakshi Sundaram sir has served as Dean of various government medical colleges in Tamil Nadu for more than 10 years. He has served as Vice President ISA National 2016 and former President of ISA Tamil Nadu, former Secretary of ISA Tamil Nadu. He has got Best Doctor Award from Government of Tamil Nadu. He has got Best Teacher Award from Tamil Nadu Dr. MGR Medical University. He is a popular Tamil poet, released 11 Tamil poetry books, recognized by Tamil scholar by Government of Tamil Nadu. I request all anesthesiologists and faculties to support Dr. A.L. Meenakshi Sundaram sir. I wish you, sir. Thank you.
Meenakshi, you are muted. Meenakshi, you are muted.
At the outset, I thank my president and the secretary for acting as propaganda secretaries for me. So on my part also, I request all anesthesiologists to support me for my candidature as ISA National President-elect. So today, our 21st theme, ultrasound guided regional analgesia. See, everybody will be fond of these ultrasound guided blocks. When I visited Kerala in the Perindalmanna conference, I have seen this fantastic team in which Dr. Sajeesh was taking active part. At the time, Dr. Sajeesh, Dr. Jitendra, Dr. Nazar, so many people are there, but really I was thrilled to see that. So with the same team in the dais, I announced, if I have a chance, I will conduct a workshop with all these faculty. So in Theni, when I was the dean, I conducted the faculty ultrasound guided nerve block workshop with that Sajeesh team. Just because he has attended that for Puthukkottai, we have introduced to Swarna team. So in Kerala, they are doing extremely well. But what I feel, the necessary focus is not given to that people. They are all so experienced. And in Theni, when we conducted, it attracted national importance. Same thing is going to happen in Puthukkottai also. Here, our youngest faculty, Dr. Jose John, is a postgraduate in Thiruvananthapuram Medical College. Basically, he is from Palakkad, Kerala, but he graduated MBBS from Tumkur, Karnataka. So, see, he is a good footballer. He's a good footballer. He's a great athlete. You can see that. But more than that, the best introduction will be, he is a bachelor. He is an eligible bachelor. So, he is a hero, looking like a hero only. He will be directed by Dr. Sajeesh today. So minimum 750 people will be witnessing this groom. So we will wait whether this Puthukkottai Bhudhan episode clicks a matrimony. Thank you, Jose John, for accepting our invitation. It will be followed by Dr. Neetha Jose.
Thank you, sir.
Who is an assistant professor in Medical College. And madam is interested in ultrasound guided regional anesthesia. And more than that, she is interested in pediatric anesthesia. That is the toughest area. So madam is interested in perioperative pain control, and she is interested in teaching both undergraduate and postgraduate. And luckily, she is in a medical college so that the teaching skills will be utilized by the students. And we are very happy a person who is interested in ultrasound guided regional analgesia coming as a faculty for Puthukkottai Bhudhan. And we thank Dr. Sajeesh, who has picked up this great faculty. Because in Tirukkural, it is used to be said, you have to delegate the work to a person who can do it perfectly well. So I did it perfectly well. I have given it to Dr. Sajeesh. And he has picked up Dr. Suvarna and Dr. Neetha with Dr. Jose John. And already we have approached Dr. Suvarna for Puthukkottai Bhudhan physical meeting. So that means I am also thinking in line with Dr. Sajeesh. In that way, I am very happy. So Dr. Neetha Josh will be followed by Dr. Suvarna Kaniyil. She says she is Swarna, but she is Suvarna Kaniyil. So she is also having a great interest in ultrasound guided regional analgesia. She is also interested in pediatric anesthesia, but these are all routine things. These are all routine things. But more than that, see, she is a good artist. She's a good painter. She's a good painter, artist, and see, she is interested in trekking. That is a great thing because nowadays I have seen many lady anesthesiologists. They have come in Puthukkottai Bhudhan. They are trekking. Only people with such a caliber can take part in Puthukkottai Bhudhan meeting. And see, she is a regular visitor of Himalaya. So Kailash Yatra, she is routinely going. So no surprise, she is not actually going. She will stand at the entrance of Kerala, exit of Kerala. The wind will take her to Himalayas. Her physique is like that. So it is an easy journey for her. Just like Pushpak Vimana, she is traveling and we are happy that she is going to come to Puthukkottai for our physical meeting also, Nerve Block workshop. And with the top people, they are going to be controlled by Dr. Sajeesh Gopalan. So he is a medical director and HOD of anesthesiology. In spite of being a good friend of mine for more than 20 years, he continues to be an intelligent person. That is what worries me much in spite of my association. And he is a senior consultant in the Santwana Hospital in Trivandrum. And more than that, he is from Kerala, but he is adjunct faculty for Kasturiba Hospital, Manipal, Karnataka. So his knowledge is stretching beyond the borders, and he has 26 years of anesthesia expertise. And out of the 26, more than 50%, 15 years he has spent in regional anesthesia. That is the reason why he has become an expert in ultrasound guided, and he is a trainer in nerve block workshop everywhere. He is a national level anesthesia speaker, and he is the past president and secretary of Kerala State Branch. So that is a great honor. And he is a IMA person also. So he was the joint secretary of Indian Medical Association. So he is not only concerned with anesthesiology, he is concerned with the entire medical faculty, and he is a academic member of this Academy of Regional Analgesia, AORA, and he was a past secretary of critical care medicine in Trivandrum. More than that, he has won the Hall of Fame award. So that speaks everything for his outstanding performance. He has won the Hall of Fame award. And again, these are all simple things. See, Sajeesh is a very good actor. Very good actor, but his friendship with me is real. He is not acting as if he is a friend, but he is a great actor. That too, he will act as a DSP and SP, police. See, the uniform categorically matches Dr. Sajeesh. He will be looking like a superintendent of police because the superintendent of police are not looking like that. But this great person, Kerala, is having another actor by name Dr. Muralidharan. Just because these two people have not entered into the cine field, Mammootty and Mohanlal came into fame. Or else only these people would have occupied this position. And see, he's a great script writer. He's a good director. So he has acted in dramas. I think more than 200 dramas he would have acted. And he has acted in All India Radio dramas for more than 15 years. More than that, he is a good social worker. So he has treated the earthquake victims in Gujarat and flood affected Orissa, then tsunami affected Andaman and Mumbai COVID mission. So he risks his life also. At that time also, he is acting in the interest of the society, and he is not acting as if he is interested. So that is a great thing. And he is a trustee member, Amuseum Arts Science conducted festival. So with all these, he continues to smile. He continues to smile, and we are very happy that we are having a person, friend, Dr. Sajeesh, and he is ready to participate in Puthukkottai Bhudhan. And with this, I hand over this podium to Dr. Sajeesh for his webinar. Thank you, sir.
Okay. Thank you. Thank you, my best friend, Meenakshi, for the nice words. And I don't take much time, but as a formality, I have to take a few minutes for the Puthukkottai Bhudhan, one of the best in a national level, one of the best academic program, online program I have ever seen. And that is now we are running the show is the Puthukkottai Bhudhan 2.0 version. And it was happy to the be that me and my team, Dr. Suvarna, already Meenakshi has given a beautiful introduction. I don't take much time on to introduce my friends, but Suvarna, Neetha, and Jose, we are lucky to have the best one of the best national platform experience. So thank you, Meenakshi, and of course the Munian, Dr. Munian and Dr. Kannan from Puthukkottai. Thank you for giving us an opportunity there. And of course the Satiga, the clarinet, thank you. And one more thing is that our Meenakshi Sundaram, your academic director, but Meenakshi, we need you in the national level, not restricted to the Puthukkottai and all. And I'm taking this opportunity to express our sincere and maximum effort on bringing you up to the national level. That is, it's our pride actually. You should come on to the national level. So we will do all our effort to bring you to the national level. Okay, and we will move on to the academic program there. Can I share the slides? Yes, can I help? Is it visible?
Yes, sir.
Oh, yeah, okay, fine. Okay. I will just, the main topic will be covered by the anatomy by Dr. Jose and above the clavicle blocks by the Dr. Neetha, and Dr. Suvarna will be covering the below the clavicle blocks of our brachial plexus block. But quickly, I will go through some of the basics of the ultrasound knobology mainly. So ultrasound, we know that it's a physics, basic physics behind the ultrasound. I am not going to the details of everything, but still I will narrate a few words on the physics. Don't worry that I don't take the complicated parts. But another point is that we have a machine, the monitor, and transducer. There are three major components. Of course, the patient is there. So the mechanical part, we have the machine, monitor, and transducer. And I always used to say that ultrasound is nothing but a cross-sectional anatomy of a particular area. Only difference is that we will differentiate our structures according to echogenicity. So how we differentiate the structure, that is the most important thing. Next comes the needle placement. Okay, we will move on to actually this is the key portion of ultrasound, that is a transducer and the tip of the transducer. Here we have a with the coupling medium, that means any solution or a betadine or saline or whatever may be the ultrasound jelly, any coupling medium you use to connect with the patient's body. It's a patient surface actually. From there, what happens is that we have a pulse echo process is going there. That means ultrasound transducer produces an electricity into a sound that goes into the body as a pulse, and it returns as echo, and that will be captured and
the transducer
displayed.
has
So here what is happening is that when electricity goes into the transducer, there are the piezoelectric crystals that vibrate, and the ultrasonic waves goes into the body as a pulse wave, and the return portion, that is the echo portion, again come to the foot plate, and the piezoelectric crystal vibrates, and that is converted
Yeah,
back
the
to
longer
the
it
electrical
takes
energy.
the
So the
sound to
electrical
come back
energy is converted to the mechanical energy,
field,
and the
it'll-
mechanical energy
it'll-
is converted back to the electrical energy. And from our first year onwards, we know that any electrical energy we can plot, and we are plotting the electrical energy, and that is what we see as a cross-sectional anatomy there. So a few things, knobologic portion, few things are there. One is the depth portion. So we have a different machine. I don't have any interest on these machines, but these are some of the knobs. In all other machines, we have the depth knobs. So nothing but we take like your laptop, you take your laptop, and in the upper portion of the laptop, that is your monitor ultrasound. Then the upper half, we call it as a near field, and lower half is the far field. When you are placing a probe, and almost always the top portion is skin. So the skin, then subcutaneous tissue, then next comes to the deeper structures. Likewise, it goes. So the near field, that means the half which is above is called the near field, and the other half, the bottom portion is the far field. So when the object is like this, and this is the near field, we can say that the object is in the near field or in the far field. So what happens is that this is a deeper object, so it will be displayed on the bottom portion. And what I am trying to say is that your depth, regarding the depth, you should take only one thing, that the take-home message should be your area of interest should be on the center of the screen. See, here we have the femoral artery and vein, then left to that we have a femoral nerve. So here femoral artery, nerve and vein is on the center of the screen. So you should adjust the depth of the ultrasound accordingly, so that your area of interest should be on the center of the screen. Okay. Then the gain. Gain is nothing but a clarity there. We have it here, we can have a far gain. Again, we know that the far field and near field. So we can adjust both the field, so that the far field or near field we can adjust. And the point again is here, the take-home message is that your area of interest, here the femoral artery is there, and to left we can see the femoral nerve there. So it should be, the clarity should be optimum gain, not over gain or under gain. So then we have some modes there, and commonly the used modes are the M mode is the common mode we use. The M mode is a measurement mode, and then Doppler mode and color mode, and 2D. 2D is the most commonly used mode for any ultrasound. So here then we have a color mode. We call it as a color or a Doppler mode. Here we can we put the color mode, and that when the window falls exactly on that area we are looking for, we can have a pulsatile or a uniform color change. So here the mnemonics is that BART. B is the blue reflects the flow is away from the probe, and red is flow is toward the probe. And this is very important, because not all the arteries are seen as red, and not all the veins are seen blue. If the flow is towards the artery, that means that it is seen as a red, and flow is away from the blood vessel, then it will be seen as a blue. So again, we can differentiate whether artery or vein is by, you can have vein is collapsible or compressible, and artery is pulsatile. Then we can put a Doppler mode, and we can see whether there is a triphasic flow or monophasic flow and all. Not going to the details, I'll move on to the transducer portion. We have a different type of transducer. That commonly used transducer is a linear probe. This is a high frequency linear probe. Then we have a curvilinear probe. Then we have a phase array probe. Phase array probe is mainly we use for the echo and all. These are the two probes we use, the linear probe and a high frequency probe. These are some of the probe movements, transducer movements. Okay. So here we have the transducer with the linear high frequency probe. Around 90% of our blocks can be done with this linear high frequency probe, because this captures the superficial structures. So these structures mainly the superficial. So most of our nerve blocks are in the superficial blocks. So we can capture with linear high frequency probes. Curvilinear is a low frequency. mainly for the deeper structure, like your deeper blocks, your spinal blocks, or erector spinae plane block, or truncal blocks and all. So commonly used upper limb, lower limb, and all other blocks we can done with the high frequency linear probe. Linear probe advantage is that this has got a better clarity. Again, you left side of the monitor, you can see the above is the femoral, again the same picture, femoral artery, and left side you can see the femoral nerve you can see on the left side. And could you appreciate the difference there? This is one is with the high frequency linear probe, another with the low frequency curvilinear probe. So this is the clarity difference, we can see that. So this is femoral nerve, and again here is the femoral nerve, but with even you can see the inside the femoral, we can see the fascicles and hypoechoic, hyperechoic, and inside the hypoechoic area. And what is hypo and hyperechoic? We already discussed that. Ultrasound is nothing but sonoanatomy is nothing but a cross-sectional anatomy of particular area. Only difference is that we will interpret the structures according to its echogenicity. Here mainly we have three types of echogenicity. One is anechoic, hyperechoic, and hypoechoic. We will come to that in coming slides. Okay, anechoic means the blood vessels, jet black color. So that means here the ultrasonic beams goes in and maximum absorption and minimum reflection. So the echo portion, what we already discussed, the pulse wave and the echo portion. Echo portion is minimal. So it's seen as a black hyperechoic, anechoic structure, black structure. So here the classical one is a blood vessel. So if it is a jet black structure is there, that will be again the same picture. There is an artery there. So you can see it as an artery because it's a pulsatile jet black structure, anechoic structure. Like this is an anechoic structure. So we call it as a pulsatile artery is an anechoic black circular pulsatile vein. It's again the same thing is anechoic black, but it is compressible vein is. Again, we can do the Doppler also. We can put the Doppler and check its difference in the flow also. Next one is a hyperechoic. What is hyperechoic? Hyperechoic means maximum reflection of the echogenic beams. Okay, so the ultrasound is maximally reflected back. So classical example is bone. Here the humerus bone is there. So the outer curvature only we can see. The classical is outer cortex we can see as a round hyperechoic structure. That is more of a whiter structure. Inside there is a shadow, that is a black shadow. So that's a classical picture of a bone. So bone seen as the periosteum and outer cortex seen as a hyperechoic white line, inside black. So then we have a hypoechoic. The classical one is again the one more thing is in a hyperechoic is that when we going to the next level interfacial plane blocks and the fascia covering between the muscles is a epimysium or any other fascia. This fascia also will be seen as a white line. So the hyperechoic line. So the bone and fascia is seen as a white hyperechoic line. But the difference of the fascia is that even through the fascia, the ultrasonic beam passes. But when a bone comes, the beam is not passing through that. Okay. So the hypoechoic, here again, the right side, we can see the round structure is subclavian artery, and left to that, we can see the your classical bunch of grape appearance, and Neetha will be talking about in details on that. You can see a small black rounder structure is a group of a bunch of grapes appearance. Is a hypermixed echogenicity. Okay. Then the probe orientation, another again the same picture there. Repeatedly we are saying that it is just like the cross-sectional anatomy. Only difference is by echogenicity. Okay, here we can see the right side, the cross-sectional anatomy. We can see the subclavian artery, and to the anterolaterally we can see the brachial plexus there in the cross-sectional anatomy. In a real-time picture, we can see my needle is going onto that truncal corner or a pocket there. This is that white line is a first strip there. Then right side, the jet black structure is the subclavian artery. I have deposited some local anesthetic on the bottom portion, and I have given us some local anesthetic, deposited some local anesthetic on the upper portion. So this is a subclavian perivascular supraclavicular brachial plexus. That is exactly on the probe orientation is nothing but when you introduce the needle from left side of the monitor, on the lateral side, where the needle comes on the left side of the monitor. That the needle last portion is the needle placement. we have two types of needle placement. Is it one is inline and other one is an out of plane approach. Here this block is this is obturator nerve block. I'm not going to the details, but you can appreciate 3 layer muscles there. Muscle layers are there. The one we are injecting is on deeper to that is adductor magnus, then the adductor brevis, and then the adductor longus. On top adductor longus, then brevis and magnus. So the posterior division is between the adductor brevis and magnus. So I've deposited local anesthetic between the adductor brevis and longus. That for the posterior division of obturator nerve, we can see the entire length of the needle. That is an in-plane approach. But this is an out of plane. Could you appreciate a small dark area there? This is the normally everyone says that this is the tip of needle, but this may not be the tip of the needle, maybe the shaft of the needle, because we are overshooting the target. So this is one problem with the out of plane approach. So you need some kind of expertise on performing an out of plane block. So I'm concluding that Sona anatomy is nothing but a cross-sectional anatomy of particular area, but the structures we identify according to its echogenicity. Now we know that echogenicity, this anechoic is a darker structure, mainly the blood vessels, hyperechoic mainly bone and fascia and all. Then hypoecho, the structure which are the nerves, and we are going to looking for that. And the next sessions also we'll be dealing with lower limb blocks and truncal blocks and all. The same basics remain same. So you just remember the basics what we have so far discussed. And we are now onwards. We will see some of the basic anatomy of the brachial plexus we are going to discuss. And after that we are going to chase the hypoechoic structure. That is our nerves. Thank you. So to Jose, are you ready, Jose?
Yes, sir.
Yeah.
Yes.
Sure. Carry on.
My slide is visible. Okay. Good evening, everyone. First of all, I would like to thank all the respected faculties and ISA Puthukkottai for giving me this opportunity. So we'll be dealing with the brachial plexus anatomy for now. So starting with the nerve plexus. So we have a somatic group of plexus and visceral plexus. So what is nerve plexus? It is nothing but it's a combination of fibers.
Excuse me, Dr. Josh, your slides are not visible.
Jose, your right sides are not visible. So, dear friends, delegates, you note down all your queries, and we will discuss after the session. All the talks are over. We'll take over the questions there.
Sir, if share screen option is difficult for him, we can go to the next speaker to save time.
Yeah, Jose, are you there? Jose, any issue? No problem. Neetha, ready? Jose is coming with slides. Okay. Yeah, done. Okay. Move on to the presentation mode.
Jose, you are mute.
Hello?
Yeah, please, Jose.
Okay. Am I audible, sir?
Yeah, you're audible. Your slides.
Yeah. Slide, yeah.
Just share the slides. Yeah, slides are come.
Sir, he has left the meeting room. Sir.
Swastika, what's the problem?
Sir, he has left the meeting room, sir. Maybe
Yeah,
he's,
okay, no problem. Neetha can take over. Neetha, please take. Neetha? Neetha, you are muted.
Yes, sir.
Yeah, you take. Joseph's left in.
Okay, sir.
Only left up. You just share the slides and continue. Yeah, yes, has come. Fine. Yes, put on presentation mode, that's all.
Can you see, sir?
Yeah, put on presentation mode. That. Slideshow. Neetha?
Oh, sorry.
Neetha?
I think it's fine now.
Yeah, fine. Neither it's fine. Neither it's fine. You can start. Swatika?
yes, sir.
Yeah.
Sir, actually, Neetha ma'am has also left the meeting room, and her network bandwidth is coming as low. And
Yeah,
as I can see,
Jose is back there. And
yes,
Yes,
yes.
Jose, you can start. No issue.
Okay. Okay. So, can I start?
Yeah, fine. Just put on the slideshow mode.
Okay, so we were dealing with the nerve plexus. Okay, so we were dealing with the nerve plexus. Somatic plexus in the right side and the visceral plexus in the left side.
Just put on slideshow mode.
Okay. Right. Okay.
No, slideshow.
So this somatic nerve plexus, they arise from the somatic nerve plexus. They arise from the ventral.
No, could you put on slideshow mode?
So we have
full screen
from C1 to C4, and then from L1 to L4, and sacral plexus from L4 to S4, and the visceral plexus are given on the right side. So another is T12, the spinal nerves doesn't participate in the peripheral nerve system.
Yes, Jose? Jose? Jose?
Sir.
Yeah.
Actually, this ClickNet, they have changed the platform from Gmail to Microsoft.
Okay.
So yesterday they have changed it. And it was very difficult to get the link. That is the problem now.
Okay.
As we are seasoned, we could make it up. Even the speakers, they don't require to register their names.
Yeah, normally that's not
because this time it is coming
this
like
time
that.
we are done with registered.
Even I joined late actually from 5:40. I was trying.
Okay, no problem. No issues. Okay.
Okay.
Let us try with the. Jose is back. Jose is.
Yeah, everybody, because they want to.
Like, hello, sir.
Yeah. Okay, clear. No issue. No, continue.
Okay. Pairs of spinal nerves, of which 8 are cervical and 12 thoracic spinal nerves, with 5 lumbar and 5 sacral, and 1 coccygeal spinal nerves. So as we have told, we have 8 cervical nerves, but we have only 8 cervical vertebrae. And I told the brachioplexus arise from the ventral ramus of spinal nerve. So what is ventral ramus of spinal nerve? So we'll deal with a typical spinal nerve here. So this is the spinal cord. In the spinal cord, we have the gray matter and the white matter. From the gray matter, there is nothing but the anterior horn. There arises the ventral rootlets arises. This is the motor root. And in the posterior aspect, the dorsal root arises from the dorsal root carries the sensory information and it arises. Here it gives the dorsal root ganglia. This dorsal root will join with the ventral root and it forms the trunk of spinal nerve. Immediately after forming the trunk of spinal nerve, it again divides into ventral ramus and the dorsal ramus. This ventral ramus again divides into lateral cutaneous branch of ventral ramus and the anterior cutaneous branch. The lateral cutaneous branch will further divides into anterior and posterior, whereas the anterior will divide into lateral and medial. Now, I was telling that there will be a dorsal ramus which give rise to lateral and medial cutaneous branch, and it supplies the skin and other muscles of the back. Okay, so also there is a sympathetic ganglion very next to the ventral ramus. So the preganglionic fibers, preganglionic sympathetic fibers, they arise from the lateral horn of the spinal cord and they travel through the ventral root and this white ramus communicates. Over here, the white ramus communicants will be present. From the sympathetic ganglia, the post-ganglionic sympathetic fibers goes through the gray ramus communicants and it will join the spinal nerve to supply the sweat glands and the blood vessels in the skin. So this is about the sympathetic ganglia. Okay, so does the dorsal ramus contribute to the somatic nerve plexus? As I told earlier, the dorsal ramus comes here. It supplies the skin and the muscles of the back. It doesn't contribute to the spinal nerve somatic plexus. So what are the type of nerve fibers that are carried through the nerve as well as the somatic nerve, which carries the motor and sensory fibers. The sensory fibers will be going along the posterior column and the motor fibers will be coming along the anterior through the ventral root. Also, there will be postganglionic sympathetic fibers, as I told, which arises from the sympathetic ganglia, and it supplies the nerve endings as well as sweat glands and the blood vessels. So those are the nerves, but
Yes, Jose?
Hello,
Yes,
sir.
Jose?
Dr. Josh is having some network issues again, and he has already left the meeting room.
I think by reconnecting, he thinks he can.
Hi, he has joined
He is
again.
reconnecting, but I think it is difficult. Josh, you have to rush through.
Yes, Jose, please continue. Jose, continue, please. Jose, any issue you are facing? Any?
no, sir.
In between?
Sir, I mean, it's heavily raining here, but I'm able to communicate actually.
No issue, no. Continue, please.
Yeah, sure. Okay, sir. So I was told telling the brachioplexus formation. Now moving on to the parts of the brachioplexus. From the the division and folds. The prefix type and the postfix type. Prefix, the idea is that normally I told the brachial plexus arise from C5 to T1. In case of prefix, there will be a larger contribution of the nerve plexus from the C4 level, that is the one fixed segment higher than the normal. So there will be increased supply from the C4. Then coming to the postfix,
So, George, could you, I mean, there are a lot of glitches in between. So, could you conclude a few?
Dr. Josh, you can stop.
Yes.
Sharing.
Yeah,
Dr. Josh, you can stop sharing.
No, sure. Neetha is ready. Neetha, please take. Yes, yes, please.
So can you hear me?
Yeah, yeah, well audible. Slides are visible. No issue. Absolutely no issue. Please.
Good evening, all. I'm Dr. Neetha. First of all, I would like to thank Meenakshi sir, Sajeesh sir, and the ISA Puthukkottai for giving me this opportunity. I'm going to deal with the above clavicle ultrasound guided nerve blocks. So, what is an before any block, you should do some preparations. That is pre-block preparation. That is, you should take the informed consent from the patient, ensure that there are no contraindications, and full resuscitation facilities and intralipid 20% should be available in the theater. And you should establish an intravenous access and attach appropriate monitoring. Then you should confirm the correct side of the block and ensure appropriate aseptic precautions. The first most important thing needed is ergonomics. What is ergonomics? It is optimizing the operator's physical position and interaction with the equipment to minimize strain and improve performance. This involves proper hand positioning, aligning the monitor with the operator's view and avoiding awkward postures. This is very important for a successful bow. Linear probe, that is 6 to 15 megahertz. So first of all, I am going to deal with ultrasound guided cervical plexus block. So before doing any block, you should know about the anatomy of that area. So first a few sentences about the cervical plexus anatomy. This is the superficial cervical plexus arises from the anterior rami of C2 to C4, and it gives rise to 4 cutaneous nerves. That is the lesser occipital, greater auricular, transverse cervical, and supraclavicular nerves. The terminal branches emerge as 4 distinctive nerves from the posterior border of the sternomastoid muscle. The lesser occipital nerve is usually a direct branch from C2, and a branch from C2 and a branch from C3 combine to form the greater auricular and the transverse cervical nerves. And another branch from the C3 and a branch from C4 forms a supraclavicular trunk, which forms the supraclavicular nerves. Then a few words about the ansa cervicalis. This is a neural loop in the neck formed by connecting the superior root from the C1 and inferior root from C2 and C3. This innervates the infrahyoid muscles. As I already told, so superficial cervical plexus arises from anterior rami of C2 to C4 and has 4 cutaneous nerves, lesser occipital nerve C2, which supplies the skin and scalp posterior to the auricle, Then greater auricular nerve, C2, C3, it innervates the skin around the ear, concha, auricle, and external acoustic meatus. Then the transverse cervical nerve, C2, C3, supplies the skin of the anterolateral neck and the lower part of the head. Then supraclavicular nerves, C3, 4, innervate the skin on the shoulder and upper part of the arm. To do the cervical plexus, you need to know about the cervical fascia. There are two cervical fascia is divided into two layers, superficial and deep layer. And the superficial cervical fascia is a thin layer of subcutaneous tissue. And it contains fat, platysma, cutaneous nerves, superficial veins, and lymphatics. Lies just under the skin. And the deep cervical fascia is divided into three main layers. That is, the investing layer, which surrounds the sternocleidomastoid and the trapezius, and the pretracheal layer, which surrounds the thyroid gland, trachea, and the esophagus, and then the prevertebral layer, which surrounds the vertebrae and longus colli and scalenus muscles. Then we can come to the ultrasound guided superficial and intermediate plexus block. So, the blocks given above the superficial layer of deep cervical fascia are named as superficial cervical plexus block, and below this layer but above the prevertebral fascia are named as intermediate plexus block. Coming to the indications of cervical plexus block, they are anterior neck surgeries, mainly thyroid surgery, thyroglossal cyst, branchial cyst excision, carotid endarterectomy, pinnaplasty, lymph node excision in neck, clavicular surgery or fractures, and shoulder surgeries along with the interscalene block, central venous catheter insertion, tracheostomy, carotidectomy, external carotid artery ligation, and tympanomastoid surgery. So this is the area of the skin which is supplied by the cervical plexus. Then coming to the superficial cervical plexus, ultrasound guided approach, we use a high frequency linear probe. That probe is placed transversely at the midpoint of the sternocleidomastoid. Then visualize the sternocleidomastoid, inject in the subcutaneous plane superficial to the sternocleidomastoid. This is the old method, landmark technique we used. That is fan-shaped, this local anesthetic is injected in a fan-shaped manner at the midpoint of the sternocleidomastoid. This is the probe placement and the position of the patient in case of cervical plexus block, that is supine with the head turned slightly to the opposite side. And in this picture, this is an ultrasound anatomy. Here you can see the sternomastoid muscle, and this is the spread of the injectate above the investing fascia, that is above the sternomastoid. This is the superficial cervical plexus block. Then coming to the intermediate cervical plexus block. What is the difference between these two? In the intermediate cervical plexus block, it blocks all cutaneous nerves and motor branches of cervical plexus, that is the branches from ansa cervicalis. Then coming to the equipment, this is an ultrasound machine with a linear transducers, that is 8 to 18 megahertz with a sterile sleeve and gel and a standard nerve block tray. The ultrasound intermediate cervical plexus block involves injection into the facial plane between the sternocleidomastoid muscle and the prevertebral muscles at the C4 level. In this picture, we can see the drug spread in between the investing layer of deep fascia and the prevertebral layer of deep cervical fascia. Once the plexus has been identified, the needle is passed through the skin platysma and investing layer of deep cervical fascia, and drug is injected. Here, this is the cervical plexus. You can see the cervical plexus. This is the ultrasound anatomy. Here you can see the sternocleidomastoid muscle. This is the cervical. That is, cervical plexus can be visualized as a small collection of hypoechoic nodules. The sternocleidomastoid is separated from the brachial plexus and the anterior scalene and the middle scalene muscles by the prevertebral fascia. And the drug is injected between the sternomastoid with its investing layer of deep fascia and the prevertebral facial layer. This is a place where the drug is injected. Here you can see the cervical plexus that are hypoechoic nodules. This local anesthetic can be deposited in the plane. Immediately deep to the sternocleidomastoid and superficial investing layer of deep cervical fascia and superficial to the prevertebral fascia. A volume of 5 to 10 ml of local anesthetic usually suffices. Here it's a video of superficial cervical plexus. Here you can see this is a sternomastoid muscle. The needle is coming. Here you can see the needle. It pierces and superficially drug is injected. You can see the spreading of the drug here. This is a needle with the drug spread. This is superficial cervical plexus. Now we can move on to a video of intermediate cervical plexus. This is the sternocleidomastoid. This is the investing layer of deep cervical fascia. And here you can see the prevertebral layer of deep cervical fascia. The needle is coming. Reaches our area of interest. And then the drug is injected. You can see the spread of the drug here. This is the intermediate cervical plexus block. Next, we can go on to ultrasound guided interscalene block. What are the indications? Indications include shoulder surgeries, arthroscopy and rotator cuff repair, clavicular fracture fixation, along with intermediate cervical plexus block and proximal humerus surgeries. The contraindications are there are general and specific contraindications. General includes that we all know local anesthetic allergy, patient refusal, infection at the site of injection, systemic infection, coagulopathy, and pre-existing injury of the brachial plexus or distal nerves. But there are specific for interscalene brachial plexus, that is contralateral respiratory impairments. If the patient has in chest trauma, pneumothorax, pneumonectomy, phrenic nerve palsy, or recurrent laryngeal nerve palsy on the contralateral side, it is contraindicated to give interscalene block. This is because interscalene block can lead to almost 100% phrenic nerve paralysis, which can lead to hemidiaphragmatic palsy. So these contralateral respiratory impairments, this interscalene block is contraindicated. It is also not given in severe bilateral lung disease like COPD. Equipment used is ultrasound machine with a linear transducer 6 to 15 megahertz and standard nerve block tray and 5 cm 22 gauge short bevel insulated simulating needle is used. And the patient position is supine or semi-sitting with head turned away. A slight elevation of the head of the bed is often more comfortable for the patient and allows for better drainage and less prominence of neck veins. This is an ultrasound image of the interscalene groove. Here, interscalene block is performed at the level of the C5, C6, and C7 nerve roots. Brachial plexus at the interscalene level is seen lateral to the carotid artery and the internal jugular vein between the anterior scalene and middle scalene muscles, and it lies inferior to the prevertebral fascia, superficial cervical plexus, and sternomastoid muscle. And the vertebral artery can be seen associated with this. So, of particular importance is to avoid the vertebral artery and the branches of the thyrocervical trunk. So, it is mandatory to do a color Doppler imaging at least once before inserting the needle to locate any vessel that might be in the path of your needle. The roots can also be located using a trace back method, that is by sliding the transducer cephalate from the supraclavicular brachial plexus. There is a stop light sign that is a typical sonographic appearance of three root structures aligned vertically in the interscalene groove. And the three structures normally present are C5 and two fascicles of C6. This is the stop light sign we usually see. And this diagram represents ultrasound anatomy for an interscalene brachial plexus block with needle insertion in plane technique. Spread. In this picture, you can see the needle in the ultrasound anatomy. Here, this is the interscalene brachial plexus. About 7 to 15 ml of local anesthetic is usually adequate for a successful and rapid onset block. Usually, the needle is inserted from lateral to medial. This is to prevent the injury to the phrenic nerve, which is typically located anterior to the anterior scalene muscle. Although one should be aware that the dorsal scapular nerve and the long thoracic nerve usually goes through the middle scalene, and that could be also injured. So you should be careful while placing the needle from lateral to medial. This is a video. Here you can see the structures: sternocleidomastoid muscle, IJV, carotid artery. This is the anterior scalene muscle and the middle scalene muscle. Here you can see the interscalene brachial plexus. Here is a video depicting the interscalene brachial plexus block. Here, the transducer is positioned in the transverse plane to identify the carotid artery. Once the artery has been identified, the transducer is moved slightly laterally across the neck. The goal is to identify the anterior and middle scalene muscles, anterior and the middle scalene muscles, and the elements of the brachial plexus. It is recommended to use color Doppler to identify the vascular structures and avoid them. The needle is then inserted in plane. Here you can see the needle in plane towards the brachial plexus from lateral to medial direction. Here you can see the whole length of the needle. Here, then the drug is injected, and you can see the spread of the drug here. This is the sensory distribution of the upper lip. But you should know that the suprascapular nerve supplies about 70% of the sensory innervation to the shoulder joint. Here, you can see the medial side of the arm. It is spared in all brachial plexus block. This is because it is supplied by the intercostal brachial nerve. That is a branch of the second intercostal nerve. So this is blocked. This is usually blocked by infiltrating about 10 milliliters of local anesthetic subcutaneously from the upper border of the biceps to the lower border of the triceps at the anterior axillary line to block the intercostal brachial nerve. Then, this is an anatomical illustration that shows a segment of the brachial plexus and its surroundings, muscles, and nerves. This is the place where we give interscalene brachial plexus block. This C5, C6, C7, C8, T1 nerve root. This is a middle scalene muscle, and this is the anterior scalene muscle. Phrenic nerve goes anterior to the anterior scalene muscle. And here, this is a place where we give superior trunk block. And here you can see that a branch, suprascapular nerve branch is given off after this portion. This is the ultrasound picture. Here you can see anterior scalene muscle, middle scalene muscle, and the brachial plexus. This is a phrenic nerve which is anterior to the anterior scalene muscle. Here, this is a transverse cross-section anatomical illustration of the neck at the level of the brachial plexus, showing relationship important for regional anesthesia. Here you can see the sternomastoid muscle. Here the external jugular vein, internal jugular vein, carotid artery. These are the scalene muscles and the brachial plexus. And this is a vertebral artery. And here you can see phrenic nerve anterior to the anterior scalene. And this is a sympathetic trunk. This is thyroid gland, trachea, esophagus, and you have recurrent laryngeal nerve here. So if drug spreads to the phrenic nerve, it can lead to phrenic nerve palsy and hemidiaphragmatic paralysis. And if it spreads to sympathetic nerve, it can lead to Horner syndrome, and recurrent laryngeal nerve, it can lead to hoarseness of the voice. There comes the side effects or complications of the block. That is, side effects are Horner syndrome, phrenic nerve block, and recurrent laryngeal nerve block. Complications can be epidural or subarachnoid injection, hematoma, intravascular injection, local anesthesia toxicity, pneumothorax, and injury to the long thoracic nerve or dorsal scapular nerve can occur, and injury to the brachial plexus nerve root can also occur if we are not vigilant. Next is supraclavicular brachial plexus block, ultrasound graded, and the landmark and positioning of the patient is like similar to that of this positioning is similar to that of interscalene. That is supine, semi-sitting, or slight lateral position with the head turned away from side to be blocked. Scanning is usually started just above the clavicle, approximately at its midpoint. This is an ultrasound scan of the supraclavicular region, typically used for performing supraclavicular brachial plexus. This brachial plexus can be seen as a hypoechoic, dark, round or oval structures. This is postero-superior to the subclavian artery. The first rib is seen as a curved line, white line, and the pleura appears as brilliant sliding lines. And this brachial plexus has a honeycomb appearance. Boundary include middle scalene muscle. This depicts anatomy relevant to the supraclavicular brachial plexus in a cross-sectional view. This is diagrammatic representation to get a clear picture. This is a subclavian artery. Posterolateral to that is the supraclavicular brachial plexus. This is the upper trunk. This is the middle trunk and the lower trunk. Here you can see one artery. This is dorsal scapular artery. So you should do a Doppler scanning before giving block in all cases. Here, this is a needle puncture. At least you have to at least 2 needle punctures you have to do in case of supraclavicular plexus. First in the corner pocket and first in between the upper trunk and the middle trunk. Here you can see the first rib, middle scalene muscle, anterior scalene. This is the ultrasono anatomy. The brachial plexus is seen as bundle of hypoechoic round nodules just posterior and superficial to the artery. This is superficial, and this is the upper trunk, middle trunk, and lower trunk. Superficial and lateral branches come from C5 to C7. Deeper and more medial are C8 and T1. A color Doppler should be routinely used prior to needle insertion to rule out the passage of large vessels, dorsal scapular artery, transverse cervical artery, suprascapular artery in the anticipated trajectory of the needle. Here in this, you can see the dorsal scapular artery between the upper trunk and the middle trunk. So you should be very careful while doing the block. This represents the 2 separate injections required for the nerve block of brachial plexus. That is, first you have to inject at the ulnar pocket or corner pocket. This is a place between the subclavian artery and the first rib. This is the, and then the needle is withdrawn and given in the upper part. This is a sensory distribution. Here you can see the T2 is paired and it is given by subcutaneous skin infiltration. And coming to the complications, it is pneumothorax, which is due to the proximity of the pleura that you have already seen in the sonoanatomy. Then phrenic nerve block due to hemidiaphragmatic paralysis, Horner syndrome due to sympathetic chain involvement, and vascular injury and nerve injury. This is a video showing the supraclavicular brachial plexus block. This is the subclavian artery. This is the supraclavicular brachial plexus. You can see the needle is coming. First injection is at the ulnar pocket, that is between the subclavian artery and the first rib. You can see the needle is coming, and now drug is injected at the ulnar pocket, which will push the plexus upwards. You can see clearly this one needle. And then withdraw and give it between the upper trunk and the middle trunk here. About 20-25 ml is used for supraclavicular brachial plexus block. Next, an ultrasound guided superior trunk block. Usually, nowadays we use superior trunk block plus intermediate cervical plexus block for shoulder surgeries, and or proximal humerus analgesia and anesthesia. There is significantly less phrenic nerve involvement. This superior trunk is formed by C5 and C6 nerve roots. This is ultrasound anatomy. Here you can see the superior trunk. The suprascapular nerve lies on the superficial lateral aspect and is the first nerve to branch off of the superior trunk and must be identified and adequately blocked while performing a superior trunk block. Here this is the middle scalene and anterior scalene. This is the suprascapular nerve. In this picture, you can see this is the place where we give superior trunk block, and the arteries passing through these places are transversocervical artery and dorsal scapular artery. So, transversocervical artery and dorsal scapular artery can both cross over under or through the brachial plexus and interfere with needle placement in superior trunk block. In this ultrasound anatomy, you can see the transversocervical artery. So, you should choose a point in the superior trunk. You should choose a point in the superior trunk proximal to the takeoff of the suprascapular nerve and without an overlying vessel. That's all for now. Thank you.
Thank you, Neetha, for the excellent presentation. Without sparing much time, Suvarna, are you ready? Yeah, we can start. Suvarna will be dealing with the below the clavicle blocks. Over to Suvarna.
Good evening, all. At the outset, let me thank Meenakshi sir for giving me this opportunity. I'm feeling very sorry that our presentation was not very good because of the internet issues. So my job is to cover the below the clavicle blocks. So in the beginning, so I have nothing to disclose, but I have taken most of the pictures from the internet, mainly from the NYSORA site. We all know that there is a growing interest in the ultrasound guided regional technique, because the earlier blind techniques usually rely on the indirect evidence, whereas the ultrasound gives the real-time visualization. So I'm not going to the USG principle, which is already covered by Dr.Sajeesh and others. So we usually go by the in-plane approach or inline approach. Before you start doing any blocks, remember about the scanning, that your supplies, positioning, ambience, the patient identification, transducer, select the appropriate transducer, all these things has to be remembered. And I don't think I have to stress more on the standard monitoring and the pre-medication before any painful procedure. And the ergonomics also for your comfort level. And we missed the detailed discussion on the brachial plexus anatomy, but you should have a thorough knowledge about the brachial plexus anatomy to select the various approaches for the required procedure. And you should have an idea of the dermatomal, myotomal, as well as the osteotomal coverage to select what approach is required for that particular surgery. There are different approaches for the brachial plexus block. So we already had a discussion on the above the clavicle approaches. Now I will discuss the below the clavicle, mainly the infraclavicular as well as the axillary approach. In the infraclavicular, of the different approaches of the brachial plexus block, infraclavicular is the deepest ultrasound window because it is here the neural structures are placed almost 4 to 6 centimeters below the skin. Here, the cords are placed around the second part of the axillary artery. Infraclavicular is simple at the same time very challenging because you can easily identify the axillary artery, but you can see your needle placement is very acute. So this acute needle angle gives difficulty in visualizing the needle as well as the target simultaneously. So it is a simple as well as very challenging block. This is the anatomy in which the brachial plexus cords are placed around the axillary artery. The posterior cord, lateral cord, and medial cord are placed around the axillary artery, you can see. So from skin, it is the pectoralis major and the minor. Then the axillary artery and vein you have to identify. And around the axillary artery, you can see the structures, lateral, posterior, and the medial cord. The main importance of the infraclavicular block is it is ideal for catheter placement, because the musculature of the chest wall, the pectoralis major and minor, that will help to stabilize the catheter and prevents the dislodgement, unlike the other superficial blocks like the supraclavicular and interscalate. So for catheter placement, this is more ideal because retaining the catheter is more easy because of the musculature, the pectoralis major and minor, that will prevent the dislodgement of the continuous catheter technique. So it is ideal for continuous catheter technique. Indication is same as for the supraclavicular, as Neetha already said. Patient is positioned with the arm by the side, but we can improve the visualization by abducting the arm. But it may be difficult in a painful situation, whenever there is a fracture. So it is easy to place the arm by the side, but if possible, keep the arm abducted with the elbow flex because it improves the visualization, because it raises the clavicle and reduces the depth to the plexus. Transducer is usually placed just medial to the coracoid process and inferior to the clavicle in an approximately parasagittal plane. You can scan from medial to lateral to locate the pleura because you should avoid the pleura. So you place them in a parasagittal plane just medial to the coracoid process and scan from lateral to medial. You can identify the pleura. In this red arrow, that the bright white glistening structure is the pleura. So you should avoid or you should place the block with the probe lateral to the pleura. So your idea is to pass the needle below or posterior to the artery and place the local anesthetic post the artery where the posterior cord is situated. Usually with a single injection itself, the local anesthetic will spread around the axillary artery to cover other cords like medial and lateral cords also. The angle is usually advanced at an angle of 45 to 60 degrees from cephal to caudal direction. You can see the local anesthetic is deposited mainly at below the axillary artery around the posterior cord. It usually spread in a U-shaped manner to cover the other cords also. If the spread is not adequate, you have to redirect the needle to block the medial cord. This video shows the how the needling is. You can see the needle coming and going to the posterior aspect of the axillary artery to deposit the drug. You can always do the hydrodissection to locate the needle. in the in-plane approach, you can see the whole of the needle. Or if you have any doubt, always do the hydrodissection to see, allocate the tip of the needle. So we go behind the means or the posterior aspect of the axillary artery and deposit the local anesthetic, and it will spread around the artery in a U-shaped manner. If the spread is not adequate, you have to redirect the needle to cover the medial cord also. And if you are finding it difficult to do the needling, because you, as I said, you need a very acute needle angulation. So if you find it difficult, you can do a healing maneuver with this infraclavicular approach. That means the caudal end of the probe is pressed and the cranial end of the or the cephalic end of the probe is lifted a little. This pressing of the caudal end of the probe will improve the needle visualization, especially in classic infraclavicular approach. The finding of the needle near the nerve structure is difficult. So with this healing maneuver or pressing the caudal end of the probe deeply, you can visualize the needle tip reaching the neural structures easily. Another is arm abduction. I said you can do this technique with the arm by the side also, but by keeping the arm in an abducted position at a 90 degree, the structures or the distance to the neural structures is reduced. So the visualization is improved and the needling is quite easy. So arm abduction also is helpful in needling. So there are different alternatives or different variations to the infraclavicular blocks. In the classic approach, what the difficulty is the needling, because there is an acute angulation is required. So different modifications have come up. One of the modification is the raptor or the retroclavicular approach to infraclavicular block. Because as I said, in the classical approach, the needling is very difficult. So what modification here is, the needle is inserted behind the clavicle from the supraclavicular fossa and is directed in a cephalocaudal direction. So in the classic approach, the needling was done from the infraclavicular fossa itself. But there we require an acute needle entry. Here in the retroclavicular approach, the needling is done from the supraclavicular fossa or behind the clavicle, and in a same angle, the direction is same, cephalocaudal direction. Actually, it improves the needle visualization closer to the cord, but there's a danger because there is a risk of injury to the suprascapular nerve as well as the vessel. So it is not much recommended these days. Another variation to the infraclavicular block, costoclavicular block. In this, the costoclavicular space or the space between the area between the clavicle as in the first rib in the medial infraclavicular fossa is used. Here, as the brachial plexus elements traverse this space, these elements of the brachial or the cords are clustered together. They are closely and very compact and very superficial in this area. That is in the medial infraclavicular fossa between the first rib and the clavicle. That is called the costoclavicular space. So here the plexus elements of the plexus are very superficial as well as quite compact. So you can do a single needling is sufficient and require a less local anesthetic volume compared to other blocks, other approaches. This is comparing the pictures, comparing the classic infraclavicular as well as the costoclavicular. In the classic infraclavicular, you can see the cords are arranged around the axillary artery, posterior behind the medial between the artery and vein, and the lateral on the lateral aspect. Whereas in the second picture, the elements of the brachial plexus are arranged quite close and compact lateral to the axillary artery. So a single needling is enough, sufficient for blocking in the costoclavicular area. That is the main advantage of costoclavicular approach. Positioning and is same as the infraclavicular, but the transducer is placed below the clavicle in the medial infraclavicular fossa, and it should be directed towards the cephalic. Like in supraclavicular block, we are placing the probe in the supraclavicular fossa and viewing into the thorax. This is just a mirror image like of the supraclavicular. We are placing the probe in the infraclavicular fossa and looking above. So in the supraclavicular and the costoclavicular are facing each other actually. You can see the structure, this anatomy structure. You can see the axillary artery as hypoechoic structure, and on the lateral aspect of the axillary artery, you can see the cords are placed quite compact structure. The video showing the needle coming to the block the postclavicular area. You can see the whole of the needle and it deposit the drug. Always, whenever you are in doubt, always do a hydrodissection. Usually, single injection is sufficient for the costoclavicular area. You can see nicely that it is getting lifted up. You don't need to separate each bundle, but you have to place the drug around the neural elements. Coming to the next block, the axillary approach. Here in axillary approach, we are targeting the terminal branches of the brachial plexus, that is median, radial, ulnar, and musculocutaneous nerve. But the musculocutaneous nerve usually departs from the lateral cord in the proximal axilla itself. So it usually gets paired in the classic axillary block. And so it has to be blocked separately. In the axillary approach, the probe is placed transversely at the intersection of the pectoralis major and the biceps insertion. And you can move the probe in a proximal to distal movement to identify the structures. Mainly it is quite easy and very superficial structures are. You can see the axillary artery and the vein, and the nerves are seen around usually the radial nerve below the artery, and the musculocutaneous separate, and the radial ulnar you can see. You can usually the radial is posteromedially, and the median anterolaterally, and the ulnar medial to the artery. And the musculocutaneous has to be blocked separately because it is away from the artery. In a separate, it has to be blocked separately with a small amount of local anesthetics. This classic picture is not always seen, because there are several variations in the structures, and the nerves arrangement around the axillary arteries often varies. If the structures are seen in the classic position, your primary aim is to deposit below the axillary artery. Inline approach going below the artery and placing there. The problem with axillary block is you may need to block, you may need to do multiple punctures because it may not get spread adequately to cover all the nerves. So you may need multiple blocks as well as the sparing of the musculocutaneous nerve, as I said. So that also has to be blocked separately. And intercostal brachial nerve, as Neetha said, it also has to be blocked separately if the surgeon requests they are going for a sorry. Yeah, sorry. So intercostal brachial nerve, the medial aspect of the arm is supplied by the intercostal brachial nerve, which is spared in almost all the approaches of the brachial plexus block. So this also has to be blocked separately, usually by a subcutaneous injection around the medial arm, anteromedial aspect of the arm. That is sufficient, around 3 to 5 ml is sufficient. We can go for the ultrasound guidance also. And some of the elbow and wrist blocks or the forearm blocks also you can learn. But as postgraduates, you may not need to learn these things. But when in practice, sometimes you may miss some of the elements, and you may get a patchy blocks. In that case, you can supplement your block with these individual nerve blocks. They are mainly used in the hand and wrist surgery as a rescue blocks whenever there is a patchy proximal blocks. For a single nerve, you need to give maximum 4 to 5 ml only. I think is there time to describe all this?
Oh no, we can skip on that individual nerves.
Are not required for the postgraduate aspect because but they are very easy, very easy as well as very helpful in your practice. Once you have passed out, you can learn all these things. Radial nerve near the styloid process, and some of the tips to optimize your imaging. You can always go for a shallow angling of needle, because if your needle is passed in an acute angle, it will be difficult to visualize your needle. And always try to rotate, or with some minor movements of your transducer, try to see the entire needle in an inline approach. That will save you without going into puncturing into the unwanted structures. And if you want, you can use an echogenic needle that also improve the visualization. And always, whenever you are in doubt, go for a hydrolocation. And nowadays there are several need recognition software also available. You can optimize the image by your tilting moments or some rotation moments. And more importantly, you will see only what you look for, and you look for only what you know. So a thorough anatomical knowledge is very essential for the success of any nerve blocks. And the pattern recognition from the ultrasonographic image needs practice. So practice, practice, and practice. So as postgraduates, even if you are not getting a chance, you observe your colleagues, senior colleagues doing and practice whenever you get a chance. You at least try to do the scanning technique, even if you don't get a chance to do the needling, because pattern recognition needs practice. And once you pass out also, you should stay current. You should read the journals regularly, because nowadays, every day newer new blocks are coming up in almost one block every week or like that. So you should read the journals regularly and participate in conference, CMEs and online forums like this to stay current with the latest techniques. Okay, once you pass out also, you should stay current with the profession. Thank you.
Thank you, Neetha. Thank you, Suvarna, for the excellent talk again. Thank you. Meenakshi, can we take questions? Is it there in the chat box?
Yeah. Questions in the chat box. No questions in the chat box because it's going to give you a demonstration.
So, what
you
surgeries you
can
give
pass the
block? Will the block give as inferiorly, not spreading above also? Will the block given inferiorly, not spreading above also? That I didn't get. But Neetha, could you take?
The superior trunk block is mainly given for shoulder surgeries, shoulder arthroscopy, rotator cuff repair, and all, along with the intermediate cervical plexus block. Here, the advantage is that phrenic nerve paralysis can be avoided. Can be not fully, but can be avoided when compared to interscalene block. Anything to add, sir?
Will the block given inferiorly, not spreading above also? I didn't get any idea. But anyway, superior truncal block actually which blocks at the, you know that at the proximal portion of the interscalene groove there is anteriorly we can have a phrenic nerve there, at very close to the upper trunk there. And the root or upper trunk there is very close to there, and there is normally it's associated with your accessory and your ascending cervical artery. It's a part of a thyrocervical trunk. Thyrocervical trunk we can have a suprascapular arteries and other arteries all that, but ascending cervical artery may be there, and along with the phrenic nerve there, the proximal most portion of our interscalene groove. So as we scan down a little down, and the phrenic nerve moves medially and goes towards the your carotid your vascular bundle there. So that at a little down lower position, there comes your spar arrangement, because there is a suprascapular nerve comes out from the root, and then we have an anterior and posterior divisions of the upper trunk. That is, we call it as a spar arrangement. Suprascapular on the lateralmost portion. So the advantage here is the suprascapular nerve is the nerve which supplies the shoulder, predominantly the infraspinatus, supraspinatus, all of the major muscles. So any shoulder surgery, especially scopy surgeries or an rotator cuff injury or other surgeries, shoulder surgeries, predominant shoulder surgery, you have to address the suprascapular nerve there on, and of course the upper trunk, C5, C6 root. And advantage, as Neetha said, is that we can avoid the phrenic nerve if we use a smaller volume. Actually, it's an volume that is which catches the phrenic nerve. So if you have a smaller volume of 10 to 15 ml and all, with no need 7 to 10 ml is enough on that area. Then we'll absolutely, most of the time we can avoid the phrenic nerve injury. But there is a problem that even with the supraclavicular brachial plexus, we have around 40 to 40% of persons, we can have an accessory phrenic there. So you should be careful on the other side, any diaphragm paralysis on the other side and all, performing any block on the above the clavicle blocks. So inferiorly spreading along, definitely it goes inferiorly. If you give an infraclavicular block, that your dye study shows that it spreads on top, but unlikely to catch the phrenic nerve. Okay, any other questions? Yeah, anything there?
Sir, I have checked the portals. Sir, there is no other further questions, and I'm checking in through it again. And
sure. Since there is no other questions, I will just highlight some of the things. Is that thank you, the excellent talk by the Neetha, Suvarna, and of course the Jose has got some issues on the net connectivity, and here in Thiruvananthapuram where the Jose is here we have a heavy rain. The monsoon is very heavy, and some internet glitches are there. That is the problem with the Jose there, and sorry for that. And then we have any block, as Suvarna emphasized on that, any block, take it in any ultrasound block, we have you should address the dermatomal, myotomal, and osteotomal distribution. Whether it's an analgesic blocks, we sometimes we have to, whether it's anesthetic block or analgesic block, we have to take necessary modifications according to the surgical requirement of osteotomal, dermatomal, and myotomal distribution. And again, another one point Suvarna emphasizes is anisotropy. That's anisotropy is nothing but the degree of fall of ultrasonic beam, which reflects, that alters the visibility of the nerve. That is this texture, echo texture will change according to the degree of fall of the ultrasonic beam actually. So the tilt of the probe is another important thing. Then is superficial blocks, normally we don't need a dual technique, but we go on to the next deeper blocks and all. If there is any confusion or any deeper, especially the deeper blocks, you do a dual technique. Dual technique is nothing but you do a nerve stimulation and confirm with the double check with the nerve stimulation there. And another, Neetha was rightly pointed out there, the scout scan is very important before embarking any block, and especially the upper limb blocks, because there is plenty of blood vessels are there. There is, especially we have the thyrocervical, entire thyrocervical branches there. You can have a dorsoscapular nerve. That's mainly the third part of the subclavian artery, and sometimes it's a part of the thyrocervical trunk. It comes. Then we have a suprascapular artery along with the suprascapular nerve. Then we have a transverse cervical artery. Exactly, that's the name denotes. It's runs transversely. The problem with these arteries are that we are introducing our needle from lateral to medially. So the possibility that we can directly cannulate the artery. So this is, so before embarking any block, you confirm where is your transverse cervical artery and where is your suprascapular artery. Then you avoid a position where these are coming. And another, we always say that advantage of ultrasound USGRA is that for three things should be there a successful nerve block. That is, there should be a nerve. First thing is there should be a nerve. And second thing, your needle should reach near the nerve and not into the nerve. And third thing is your local anesthetic should spread around the nerve. So all these are possible with ultrasound, because nerve stimulator is almost 99% is accurate with ultrasound. But the problem is that once you started injecting, you don't have absolutely no control over the spread of the local anesthetic. So here the ultrasound, we can have a very good visibility of the drug spread, and especially you take a linear probe direction and all, you can see how above and below the nerves are engulfed with the encircled with the local anesthetic there. Then Suvarna very rightly pointed out two things. There is again three things are there. When you should ultrasound is never and ever a replacement for your anatomic knowledge, because the three things, your anatomy. That is very important. Ultrasound is just a cross section. Sonoanatomy is nothing but a cross sectional anatomy of a particular area. Only difference is that we will interpret the structure according to its echogenicity. And the last three things, three of the three is Suvarna again mentioned and highlighted, that is the practice actually. So the perfect practice makes you perfect. I mean, proper practice makes you the perfect one. So practice in a proper way, that is very, very important, so that you should acquire a good anatomic knowledge and follow the basic techniques. So many newer techniques are coming up. The only why I'm emphasizing is that plenty of YouTubes are coming up with the newer technique and all other things, but you stick on to the basic, I mean, a safe, time-tested, gold standard technique. You follow that. Then, of course, once you are experienced, you can do another. Especially that Suvarna was very much pointed out the raptor techniques and all, retroclavicular and all. And I know that over enthusiastically some of the OPGs are embarking into that techniques like raptor and all, going just below the clavicle and where exactly your needle, you absolutely don't have any idea, because in experience science it's okay, good one and all. But you have some point there is, you are in a black spot. Sometimes you may not be visualize the needles, and there is a plenty of things to worry just below the, not only the pleura, and many things we have there in the worry. Just you go below the deeper structures. And the last thing is that almost always you should make sure where exactly your needle is there. And the beginning I said that you are scanning your depth, your area of interest should be on the center of the screen, because so many structures are beyond that. So and their needle should be exactly where at the tip, where you should be very aware of where exactly your needle tip is there. So when I again highlighted the points, things are there. If there is any confusion there, you just hydrodissect and go. You can take any other solution. Okay, even you can use the local anesthetic also. Hydrodissect, confirm your needle tip position. Another thing, especially the classical infraclavicular block and all, giggle the needle. Just just make some movement of the needle so that you will get some idea where exactly your needle tip is there. Unless and until your needle tip is sure, you are not supposed to further proceed further. That is, it's a very ultrasound is not a very safe thing, but do it in a proper practice. Then only you will make a perfect sono and a regional anesthesia expert there. Swadhika, any questions there? Swadhika?
No, sir. No, sir.
No. Okay. Anything from the organizations? Any? One more point again, I'm just highlighting, Neetha was rightly pointed out that interscalene brachial plexus walk, we have a middle scalene is between the middle scalene and anterior scalene muscles, and the middle scalene muscles we have two very good, we have plenty of articles there, and we have in a chronic pain also, we have encountered some injury problems with these nerves, that is especially the dorsoscapular nerve and long thoracic nerve, there's latissimus, and that runs almost in the midway of the middle scalene muscle. Actually, that's so in a in plane you are going. If you are going in plane, that is good for the beginners. What I personally do is in interscalene, I go one outer plane technique, but in plane is for the beginners. It's good. You should not go deep into the in middle scalene muscles. There is a possibility of injuring these nerves. So if you want to catch in middle scale, interscalene block is mainly for the upper trunk division. So you want to catch, you never try to catch the lower trunk with the interscalene block. You take another approach, like you get deposit around 10 ml of something on the interscalene area for the upper trunk. And deposit the local anesthetic for the lower trunk with the supraclavicular technique. Another technique. Don't go through the middle scalene muscle. Okay, that's all. And superior cervical plexus, Neetha said about the superficial and intermediate techniques are there. So the investing just above the, even before, just superficial, the investing layer of the cervical area, you can do the superficial block. You just pierce, you will get a good middle scale, just intermediate approach there. Then, and the point on advantage is that it's an excellent block for You can do even awake thyroidectomy and all, but an excellent block, especially in our everyday practice for your central line cannulation and IJV and all. You just give a block there and you can comfortably put the catheter, and even fixing, suturing and everything you can comfortably do after just giving in a superficial or intermediate cervical